So thank you again for the invitation to come. The last time I was in this room, I was interviewing for fellowship. So it's a pleasure to come back many years later. And we're going to talk about some of the work that we've been doing. And I'll start off by acknowledging our research team back at SickKids in Toronto. We really have an amazing team. I think we all love coming to work every day. And it's really all these smart and bright students that inspire us to move the field forward. These are my mentors. So some of you may recognize Karen Gordon. So I was the first master's student in her lab, and she really drives our research from an audiology standpoint. And then Dr. Blake Papson is my surgical partner and has been a longtime mentor. And so indeed, what I'm going to show you today is a lot of the fun that we've been having looking at the vestibular system in our kids with cochlear implants. Now, many of you in this room are familiar or you perform cochlear implants. And I think it's been a remarkable addition to our toolbox as otolaryngologists to be able to restore hearing in a child or in an older adult. And if that wasn't enough, what we're going to focus on today really is what they've given us beyond the clinical benefit. And we're going to focus on what they've taught us in terms of brain development in children and really focus on where they've driven us from a research standpoint. And I'm going to start off, as we often do in pediatrics, with a parental observation, which often drives our research questions and helps us focus where the need is in terms of functional outcomes. And so this is a young girl who has bilateral cochlear implants and an intact vestibular system. And what mom said to us is that she has two different processors. So they're different generations, and so their battery life is different. And so during a practice or during a competition, if one of her processors ran out of battery, mom would notice an instant decrement in balance. And so let's just look at what that looks like. And so again, she's got incredible balance. So here she is in the bilateral condition. And then we've created a unilateral condition. We've changed the electrical milieu of her inner ear, and that has led to a decrement in balance. It's a temporary one, so you'll see very quickly over time, she adjusts to that new environment to the point where she's able to at times land the jump in the unilateral condition. But we're going to look at the environment that we put these kids in terms of all of their senses. We're going to think about hearing and the vestibular system together and not separately as we often do. So we'll keep coming back to her throughout the talk. When we think about the labyrinth, again, it is one organ, but I think, again, we often think about it separately. And when we first began thinking about the vestibular system, what drove things along, particularly in the pediatric domain, was our concern as implant surgeons about what we might do to these children if we put in bilateral implants simultaneously. And that's certainly where our story began at the Hospital for Sick Children. And so certainly we know that there are negative effects to cochlear implantation. We're going in there as gently and as softly as we can, but we're still putting an electrode in the delicate middle ear. And so there is a possibility of creating an injury in the vestibular system. And these have been shown in terms of loss of VEMP and distortions in the microanatomy. And so because of that question, we began to look at vestibular function in our children when we began to think about doing bilateral cochlear implants. And what we found was that 70% of these kids had an element of vestibular dysfunction. Sometimes it was mild. But if we really focused on the group of children who had significant impairment, complete areflexia, that in the literature is somewhere between 35 to 40%. In our cohort, it's 38%. And so that makes vestibular impairment the single most common associated feature of sensory neural hearing loss. But at times, we don't often look for it in our children who present with hearing loss. Now, it's important, just as it is in looking at hearing, to look at the functional measures. And so when we started measuring vestibular function, we also began to look at a balance outcome measure. And I am not fortunate enough to have a physical therapist work with me in the clinic. And so we needed to find a test that I could administer as a surgeon. So it had to be simple and it had to be quick. And so what we landed upon was the Bruininks-Oseretsky test of motor proficiency. And it's a great little test, doesn't cost very much. And it takes less than 10 minutes to do, and it comes with age and gender standardized norms, which is really important in children. So these are the subtests, but I'll show you, this is what it looks like. So here we have 2 children who are matched for age, gender, and t-shirt color. And you can see we have a little balance beam down here, and we have a white line, and we have a target for them to look at. And you can see that they have very different balance skills. This child needs me to help him stand up. Look at this. His shirt says surf tour. Do you think this kid is going to get up on a surfboard? I don't think so. Not with those balance skills. Compared to this child, and you don't even see me in the frame, he's able to do all of these tasks without difficulty. And this child here has Usher syndrome. So he has bilateral congenital hearing loss, congenital vestibular loss, and he's going to lose his vision. And so one of the challenges is, though, if you watched him come into my clinic, he actually runs into my clinic. And so oftentimes people say, well, I just don't see this in my clinic. And that's because they're looking for the non-ambulatory child. And children ambulate when they have bilateral vestibular loss. They can't stand on one foot, but they can ambulate. And so when we look at the data in our cohort, this is what we see. These are normal hearing children. So we ran our own normative data in addition to what comes with the test. These are all comers with hearing loss, most of which are bilateral profound and have cochlear implants. And you can see that they are significantly poor. But some of these children have normal vestibular function and some do not. And so if we take out the children who have bilateral vestibular loss, this is their performance. And you can wonder, what's it like to navigate the world with bilateral vestibular loss? Well, you navigate it like a 4.5-year-old. And so if you think about your average 4.5-year-old, think of the things they can do. They can walk, they can run, they can jump. They probably can't ride a bike without trainers. And so that is why we miss these kids, because we're looking for non-ambulatory kids. And while it's pretty good to be able to do what a 4.5-year-old could do, we wouldn't be happy with that in the domain of speech and language. If bilateral implants only got us to the language age of a 4.5-year-old, that wouldn't be nearly the success that we see. But meanwhile, we do accept this when it comes to bilateral vestibular loss.
I'm sorry, and you're diagnosing, your gold standard for diagnosing bilateral vestibular loss is
calorics, rotational chair now replaced with VHIT, and OVEMP and CVEMP.
Great, thank you.
And so, we'll travel over the world and people will say, like, what's in the water in Toronto? Because, like, what's happening with these kids? Are you putting gentamicin in the water? Because we really don't see this. And again, throughout this lecture, you'll see there's this dichotomy of these kids have problems, these kids do well. And I'm going to give you a really good example of a child who does well in certain domains. So this is a young boy who had meningitis. And what you can see is that he can't stand on one foot with his eyes closed. He can't do what a 5-year-old can do. But here he is practicing, and he swam in the Deaf Olympics for Canada. And when you look at him in a pool, you think, wow, he's an athlete. How could he have bilateral impairment? Well, watch him coming to the wall. Look at that flip turn. See, he deviates over to the side. That's because he momentarily loses visual fixation on the black line at the bottom of the pool. That's how he's staying in his lane. Now, as a clinician, I say, well, that's pretty good for a kid with bilateral vestibular loss who survived meningitis. But he says to me, Dr. Cushing, make it better. Because I don't want to just swim in the Deaf Olympics. I want to swim in the Olympics. And those milliseconds matter to me. And so this is what really behooves us to think about how we can get these children to do even better. Now, another great Canadian example. This is our annual cochlear implant skating party that we put on for our kids with cochlear implants. And so this is our little guy with ushers. Like, is this not the Canadian dream? No vestibular system, and he's up on skates. So we needed to capture a video of it because this is a remarkable view of plasticity. But then this happens. It's hard to watch. I've seen this video hundreds of times, and I wince every time. And he took that on the chin. His arms did not go out. He did not have an appropriate fall response. He took that on the chin. And when we captured this video, we had a bit of an aha moment. We said, this kid has had 2 implant failures, 1 on each side. And we went back and revisited some old data that we had looked at, looking at our implant failures. And we had noticed in that paper that children with meningitis had a much higher prevalence of implant failure. And in our discussion, we had made up some theories as to why that might be the case. And other people had noticed the same thing, but we were wrong. What we had missed was that those kids with meningitis had vestibular impairment, and so they fell more. And so we went back to our data and we looked at the end organ function and the balance data that we had. And so these are our standardized normals. These are our children who have not had a reimplant, and these are our children who have been reimplanted. Now, the surgeons in the room and the audiologists may say, well, of course they have worse balance. You've been in there twice with an implant. And the truth is that a lot of this data was collected before children had bilateral implants and sometimes before they had any implants. And also many of them had etiologies consistent with bilateral deafness. And so there was a higher predisposition for meningitis and Usher's syndrome. Many of them also had bilateral vestibular loss in both ears, but implants only on one side. So we really felt strongly that this was a reflection of their etiology of deafness and not the idea that they had been reimplanted. We looked beyond balance and we did caloric testing, rotary chair testing, and VEMP testing. I'm just going to show you the caloric data, but what we saw was that the proportion of children with bilateral areflexia in the reimplanted group was significantly higher than those who hadn't had an implant. And so what this led us to think about is that bilateral areflexia increases the odds of implant failure. Again, because these kids are navigating the world, and it may not always be causally related in that they hit their head and they break their implant. Sometimes that's the case, but even just how they lay their head down on the pillow every night is different than you and I. And so there's some feeling that there may be an element of microtrauma over time that leads to fatigue and led to implant failure. And so we counsel families now when kids come in that they may have an increased risk of implant failure in the setting of bilateral loss. So I've just mentioned how common it is. I hope I've given some indication that it's important. And now the challenge becomes, how do we identify it? Because we're all busy clinicians and we all have experts in our department who are very good at identifying it, but can't handle the load of all children with hearing loss. Probably can't even handle the load of all children with cochlear implants. We're not even able to do that in Toronto. And so this is a screening assessment that we created. And for those of you who know Blake Papson, this story will resonate. So he said to me, listen, Sharon, I'm not going to spend more than 2 minutes on this. So you got to give me something that I'm going to be able to do in 2 minutes so that I know who to send to you for more testing. And so this is what we came up with. And so let's start talking about motor milestones. And so this in and of itself can really open the door to knowing which children have vestibular impairment. And the truth is parents don't know to mention about these deficits. They have no idea that there's two parts to the inner ear and that balance can be related to hearing. And so children who have not developed head control by 4 months, who are not sitting by 9 months, and who are not walking by 18 months, while there's lots of things that can cause this, this is a good screening assessment. Blake found this even a little bit too hard, so we changed it to 4.5 months, because then you only have to remember one number and you either just divide or multiply by 2. So 4.5, 9, and 18. And so this in and of itself can help you identify who needs to be screened. Now, many parents can't remember, when their child walked, but I can tell you that most of those kids are normal. The kids who walked late or who did something late, that will be forever burnt in the memory of that parent. And so the minute you ask the question of, did your child, when did your child walk, the floodgates open, because they tormented themselves as to why their child was not walking along with the neighbor's child. The next thing is an assessment of motor function, and we've talked a little bit about one leg standing. And so this is the test that we do for brief screening, and I've put up here what you can expect. So a 2-year-old should be able to get up on one foot and down. By 5, they should be able to do it for 10 seconds. And so this is a really great screening tool that even our audiologists do very quickly. And then they can say, Sharon, can you come and see this kid? They just do this in the audio booth. Now, we wanted to know how good this was, and we had this cohort of kids who had gold standard testing and who also had the bot testing done, where one leg standing, eyes open and eyes closed was one of the tasks. And so we prepared some receiver operating curves just to see, would this be good enough? And when we look at children older than age 5, and we look at if they are unable to stand with their eyes open for less than 8 seconds, again, good sensitivity, not so great specificity. But if we have them close their eyes and they can't do it for more than 4 seconds, there's high specificity and sensitivity that they will have some form of vestibular impairment. Children with neurologic conditions are also going to get picked up by this, but this is just a screening tool. The final one, and again, this one Blake doesn't do, and so you can stop after 1 and 2, is some form of assessment of the horizontal canal. And there's lots of different ways to do it. Here we do it, and here's an example of doing it in clinic. This is a little boy who had meningitis. You need to have some interesting targets because your nose is just not good enough. Now, the purist would say this target is too close, and we're going to get in trouble with accommodation. But we also have to not break, but bend some of the rules when it comes to pediatrics. But you can see he doesn't mind when I'm moving his head about. And watch this great big saccade back to the center. And so again, while we can then send this child on for additional testing, we have a sense of how he's performing in the clinic just by doing a head thrust test. And again, kids don't really mind when they're sitting in their parents' lap. One of the things in terms of technology that's really advanced our capacity to test is our ability to use VHIT. And it's really a very appropriate tool for children. Children move their heads. So here we're calibrating the Captain America goggles with the laser beams is what we call them. And you have to hold their head, and you also have to have a second tester. But they are able to calibrate these devices and to perform the test. This is a little boy who had a cranial base tumor. Now, I haven't edited this video because this is what happens, right, in the reality of pediatric testing. And he takes them off and we have to calibrate them again. So you have to have lots of time and patience. Now, you're going to see me, I'm going to start moving my hands around because literally every time I turn this child's head, he's saying, ouch, ouch, ouch. And he's kidding me, but I can't see his face. So I don't know that he's actually kidding me. So we keep moving things around. But ultimately, we were able to get a test that did demonstrate bilateral vestibular loss. And for this child, it was from ototoxicity. So this has really helped our ability to detect these things in clinic. Now, there are some pretty interesting things about the physiology of children. And so one of the things that babies can't do is visually suppress their VOR. And so we can do essentially a subjective rotary chair test in a baby. So this is my son at 3 months of age. And this is called the mom-powered rotary chair. And look at that. Is that not the most beautiful post-rotary nystagmus you have ever seen in your life? It's gorgeous. It is absolutely gorgeous. What's that? Yeah, exactly. I tossed my cookies after that. He was fine on that. So this is a really great tool for our children who come in with hearing loss. So we don't need any special equipment. It is subjective. It doesn't give us a quantitative assessment, but it allows us to predict which babies have bilateral vestibular loss. And that's really what we're looking for in these children. We're not looking for the subtle unilateral deficit. We're looking for bilateral loss. So with these 3 easy steps, this has really allowed us to consolidate. And I use this some days when I'm in my busy clinic and I happen to have a vestibular patient come in or a child with hearing loss because we don't always have time to do the gold standard. So it's been really helpful for us to have these tools in our toolbox. So when we look at the other way that we can finesse our assessment is to only test those with high probability of having dysfunction. And so again, in the red box here, these are the etiologies that are most significantly affected. Again, in this box here, these children also warrant assessment. The kids with connexin are generally pretty good. And mitochondrial and autoimmune, I've put question marks because I think the data is, we just don't have enough kids. I would suspect that if we had enough of them, we would show dysfunction there as well. We're going to focus on 2 of the interesting populations that we've spent a bit more time with recently. So we have a very, and I imagine you do here as well, a very consolidated program to follow all of our oncology kids with serial audiograms. But one of the things that we don't do is we don't assess for vestibulotoxicity. And many of these drugs at times are even more, have even more impact on the vestibular system than the cochlear system. So we've begun to look at this with our oncologists. And so far, we've tested just over 60 patients. And what we've found is that roughly 50% of them have some degree of horizontal canal dysfunction and utricular dysfunction. These are screening assessments, so they're not perfect, but they're what we do when they come down for their audiogram routinely. And so this is a protocol we're developing. We've also measured their balance, so looking at their 1 foot standing. And so this is with their eyes open. And this is the cutoff that we talked about. So again, with our cutoff of 8 seconds, 30% 35% had abnormalities. When they close their eyes again, their skill falls down, and over 60% of them had abnormalities. So again, these are multifactorial abnormalities in that these kids have at times had cranial base surgery, they've had radiation therapy, but they're a group of kids whose long-term function is going to be impacted by their balance and vestibular impairment. And so what we've been able to go back to our oncology group and say is about 50% of those kids have evidence of vestibular toxicity. We should create a routine screening program. And this is something that our audiologists are beginning to do as part of their assessment for ototoxicity in these children. The second thing that we're going to talk about is congenital CMV. And in the last lecture, we talked a lot about how we're moving towards screening universally in Ontario. And here's again an example of what happens to the stria vascularis. This is a normal cochlea, and this is a cochlea that's been infected with congenital CMV. And we know that 20 to 50% of these children will have some degree of hearing loss, but many more of them also have vestibular end organ function. And so these are screening paradigms that we're building into our universal screening protocol. Now, we're going to shift gears a little bit and begin to think about what the sensory environment does to our balance. And we're going to focus on our kids with single-sided deafness. And essentially what happens to this little girl if she has single-sided deafness is her world becomes contracted. It becomes contracted auditorily, but it also becomes contracted spatially. And so lots is known about the consequences of single-sided deafness. We know that their school performance is impaired, behavior is impaired, they fail more grades, they need more help in school. But I think the cochlea gets too much credit for these deficits. And what we've looked at is we've measured balance in these children. And this is a virtual reality environment that we have at our rehab hospital across the street. It's called the Challenging Environment Assessment Lab. And essentially we can bring these kids over and perform the bot in this environment. And we can modify the auditory environment, we can modify the visual environment. And this is what we've seen in our kids with SSD, is that they also have significant balance impairments. And if we compare this to the data I showed you earlier, these are all comers with hearing loss. So kids with SSD have just as bad balance as all comers with hearing loss, and they have about twice as good balance as those with bilateral vestibular loss. When we measure their end organ function, again, roughly half of them will have an element of vestibular end organ dysfunction, most of which is in the ear that's affected, but some of which is bilateral. And so these are kids, again, who not only have asymmetry in their auditory system, but then also have asymmetry in their vestibular system. And so really, when we begin to think about outcomes in children with SSD, we really have to think about the fact that these have unilateral labyrinthine loss in many cases and not just cochlear losses, because that might help us differentiate in terms of performance and outcome when we provide therapy by way of implants for these kids. So let's go back to where we began. I said that the context of this talk was going to be thinking about what have implants taught us about how our brain develops in the presence of a sensory loss. Now, we've continue to hear lots and lots about what the impact of sensory loss is on cognitive decline. There's some great work being done. And in particular, what's exciting is our capacity to potentially modify that cognitive decline by providing implants or hearing rehabilitation. I think when it comes to this story, we have to be careful again that we consider the entire labyrinth and not just the hearing impairment in these individuals. And certainly there's many groups that are doing that. Now, in my world, I never look after anybody who's 18. And so I don't so much care about cognitive decline, but rather I think about how do we build a brain in the presence of a sensory deficit. And that's really where we're going to spend the rest of this talk, is thinking about what happens to a child when they're born without a sense and then we partially restore it. Now, this is my second disclosure slide. And so everything I've really learned about brain development has come from two individuals. So Karen Gordon, again, has been a great mentor. And then this is my son. And I'll take a little aside in that I wasn't really sure how family and children would fit into my life as a woman, surgeon, academic. And I came to having a child, pretty late. And I was scared to death because I loved my career. And I know that sounds harsh, but I really was worried that a child might actually take away some of that enjoyment. And of course, that all went away the minute I held this baby in my arms. I never thought about that again. But what I didn't appreciate was that he would actually make my job better. Because if I was going to spend time away from him, it better be worthwhile. And he'd also make the data better, because now I had the ability to see how normal development happens. I spent my days looking after babies with hearing loss, and now I got to see the wonder of language and motor development in this little tiny human who I adored. And so really, I give him credit for a lot that I've learned and understood about the data. The data is better. So when we think about brain development, this is Lee's group back in 2001. And what they looked at is what happens to the cortex when you're deprived of a sense. And what they did is they looked at the duration of deafness. Now, the blue part here is the brain doing nothing. And so you can imagine that a 6.5-year-old deaf child, again, that cortex doesn't have anything to listen to. But over time, we see less blue because the brain doesn't like to do nothing. Right? The brain will pack up and go do something else if that sense is coming back. And until we had cochlear implants, that sense wasn't coming back. And so that's what the brain does. And so, again, brain development is a pretty tough thing for me to swallow as a surgeon and get my head around. And so this is the way Karen Gordon explains it to me as a scientist. So essentially what happens is we have these stimuli in the periphery and our senses pick them up. This is a high fidelity representation of the environment, but it's hard to process those. And so we process them and we look for patterns. Once we find these patterns, we reassemble them so that we can say, aha, that's what that is. That's my mom calling me. That's the smell of my favorite perfume. Sometimes we have to go back to the periphery and get more information. We just don't have enough information. And so practically here's an example of that. So I live near a park and there's this ice cream truck that comes by and it plays this, what I think is an annoying little musical tune so that all the neighborhood kids know that the ice cream truck is there. Now my son listened to this for his first 18 months of life. He heard this on a daily basis and I don't know what his brain did with it. He hears normally, so he created some pattern recognition. But then in and around 18 months, I said, you know what, this kid's old enough for ice cream. And so I brought him. And in that moment, that sensory experience, that ice cream cone changed my son's brain. That's how powerful sensory information is. And so that's really what we have to think about when we have impairment of those senses. And so when you have cochlear loss, again, that high fidelity representation is not as good. The processing is slower, and the information coming back from the periphery is also slower, so everything slows down. Now, what happens when we make it better? Not perfect, but better with a cochlear implant. Well, the processing speeds up. Our ability to extract from the periphery also improves. But there's a cost, effort. So we know that children with implants and hearing loss have communication fatigue. And so what we want to do is look at how the brain changes in response to that increased effort. So this is an algorithm that one of our PhD students created. We're not able to do MEG or fMRI. And so what this is 64-lead EEG that gives you MEG-like data and shows you what parts of the brain are lighting up in response to a stimuli. It's freeware if anybody wants to use it. And so what it shows us is that these are parts of the brain. What we've done is we've presented a stimulus to normal hearing kids and to children with experienced cochlear implant users. And these are the parts of the brain that light up in our cochlear implant users that don't light up in the normal hearing children. These are the parts of the brain that they're using through effort in order to make up for the inadequacies of the cochlear implant. Brand new pathways to allow them to do things with cochlear implants like detect timing, which cochlear implants don't do a good job of. So kids can do things that they shouldn't be able to with implants because they create novel pathways. And so if we think about that in the context of spatial navigation, let's think about how we develop spatial knowledge. Let's look beyond hearing and beyond balance to how we navigate the world. So we've already looked at what happens when you lose hearing when it comes to spatial knowledge. Your balance isn't very good. We've also looked at other tasks. So this is the Corsi block. So what you do, it's a spatial memory task. And so you will tap, as the clinician, you tap the blocks in a certain sequence. That sequence gets bigger and bigger until the child can't repeat it. So it's a way of doing non-language-based spatial memory. And this is what we see. So we have our group of normal hearing children, our group of children with bilateral cochlear implants who are worse, and our group of children with untreated single-sided deafness who are just as crummy as our kids with bilateral cochlear implants. That's asymmetry in the brain. We also have them do this triangle completion task where you walk them around the triangle and then you walk them to one place and ask them to complete it with their eyes closed. So it requires spatial knowledge and spatial memory. And what's interesting here is, again, normal hearing kids, bilateral cochlear implants are significantly worse. Untreated SSD, so these kids have a normal ear, are worse than our kids with bilateral cochlear implants. So in some ways, when it comes to this task, it's better to have bilateral deafness and bilateral cochlear implants than it is to have untreated SSD. Mm-hmm. Finally, again, a spatial knowledge task, same thing. These children, the worst scenario is having untreated SSD. The brain does not like asymmetry. So let's look at what happens to other systems. So if we're missing or we have a developmental visual anomaly, what happens to spatial knowledge and balance? So we tested that in a group of children with normal hearing and normal vestibular function who had strabismus and amblyopia. And what we saw is that they had poor balance. And when we compare this to the data that I've shown you previously, these are our kids with hearing loss. These are our kids with bilateral vestibular loss. And so what this really made us realize is that how these children are creating the construct and the framework for balance. You know, in an adult with acquired loss, we think about vision, proprioception, vestibular function. And we can plug and play some of those and drive compensation. But these children have built a brain without some of those major stepping stones or some of those major senses. And so how they've built it, they don't have the framework that we have in acquired loss. We have to think about it differently than we do in adults. And so finally, again, vestibular, when you have vestibular loss, again, we know that all of this becomes more difficult. And so what we're going to do, this is our kid with ushers. So that's what it looks like to land a ski jump and you don't have a balance system. And you can imagine, of course, that's going to be pretty tough, right? He doesn't have a sense of where his body is in space. And so the question is, just like we do with hearing, is that can he compensate for that with effort? If he tries hard enough in the presence of bilateral vestibular loss, can he land that jump? And it's a feel-good story. Of course he can. Check that out. Amazing. Amazing. No vestibular system whatsoever, and he's landing a ski jump. Now, that came at a cost. So if you ask his mom, how many times did he practice that? Well, he spent 3 days on the hill. He didn't make his bed. He didn't do his homework. He didn't play with his friends. And so there was a huge cost to him developing that skill, but he was bound and determined to do it, just like he was bound and determined to ride a bike, which he finally did at 15 years of age. And so kids can overcome this, but not without cost. And so let's think about the positive side. Can we make this better? So what if we make hearing better? So here we looked at the positive effects of cochlear implants, which is sort of the flip of where we began. And we looked at how kids performed in a balanced task, the BOT2, with bilateral implants on and off. And what we saw was that when we put their implants on, they did better. Not surprising. Okay? Now, what if we restore that sense? Can we restore vestibular function? Well, there are lots of groups that are trying, but is there any way that we can make that the information better coming in? And so it really brought us to this question of, can we stimulate the vestibular system with a cochlear implant? And the answer to that question is yes. And so we took a group of children and some of them had acoustic vents and some of them did not. And what we did is we attempted to find an acoustic vent, and in these children, we also defined an electric vent. So we turned on single electrodes at high pulse and high stimulation, and we were able to electrically stimulate VEMPs in these children using their cochlear implant. An intracochlear electrode was stimulating the vestibular end organ. Now, the most interesting thing is that some of these children no longer had acoustic VEMPs, either because their deafness did that to them or we did it to them as surgeons. but we were still able to electrically evoke a vent. Sounds familiar, right? And so when we look at the data, again, our electrically evoked VEMPs are faster, not surprising, just because it's a much quicker return. Now, if we restore that child's VEMP, is that going to help him land the ski jump with less effort, less trials? Perhaps. But what about if we changed his perception of verticality? So let's go back into the behavioral and look at whether or not we can drive change in perception of verticality using cochlear implant stimulation. And so how we did this is we measured subjective visual vertical. This is the inexpensive way to do it, and there's also other instruments that we use. Now, if you have an abnormal subjective visual vertical, you either tilt right or you tilt left. And the normal range for children is plus or minus 2 degrees. And so what we did is we did that in children and we stimulated their implants at the same levels that we were able to evoke VEMPs. And what we saw was that we had a group of kids who leaned left abnormally and a group of kids who leaned right. And when we turned on their implants, the left leaners shifted right and the right leaners shifted left. So we were able to correct their perception of verticality by turning on their cochlear implant at levels that evoked otolithic function. And so certainly we thought perhaps this would help the child land the ski jump, but we wondered where do the limits of this lie? And so what we've been working on is an assistive device that couples with the cochlear implant that contains accelerometers and gyroscopes. So let's see how far can we drive that compensation? How meaningful can we make that electrical stimulation? It's not going to be perfect because it's an intracochlear electrode. It's not going to restore VOR. But if we couple my head is in this position and I'm falling with a certain type of stimulus, whether it be auditorily electrically evoked or vestibular electrically evoked, can the brain use that information? And so we've tested this device on 16 children. This is our initial prototype, which was in an iPhone, and now it's an ear-level processor. And we provided them with head reference deviation signals that are electrically transferred to the implant. Here's an example of what we see. So again, this is our little guy with ushers. This was our initial testing paradigm. Again, we don't have a posturographer, so we used a Wii board. And you can see that here he is all over the place. He's got his eyes closed, but he's having a hard time staying up. Whereas here he's got enough energy left over to be distracted enough to clap his hands. And so certainly we saw initial promise with using this kind of information. The interesting thing is after this child's mom said, you know, he said to us afterwards, I never knew when I was falling to one side, I had to shift my weight to the other side. And this is a child who had tons and tons of physical therapy. But the things we take for granted in terms of how we move our body in space are not natural to these children. So when we look at the group as a whole, this is what we see. So this is with cochlear implant off, and this is with head reference stimulation. And when we look at time to fall, which is, you know, an important indicator, this is a group of age-matched normal hearing children doing the bot. This is our group of kids with cochlear implants and bilateral vestibular loss. And this is what happens when we give them head reference stimulation. So we see improvements in these mid-level tasks. They still really struggle out here. And so we have some work to do in terms of refining the signal to try and maximize what we get. But essentially, I think the important and the take-home message is that we really do need to consider vestibular function in our children with hearing loss and what we can do about it, whether it be through therapy or through other therapeutics. Because when we think about how children learn and how they develop, vestibular function sits at the base of the pyramid of learning. It actually sits above audition. Because if you can't sit still in your chair, you can't read and you can't learn. And you're spending all of your time just trying to stay upright. And our brains will prioritize, understandably, staying upright over learning. And so it's really important. And so I hope that I've emphasized that vestibular and balance dysfunction is exceedingly common, especially in our children with hearing loss, that it matters to us as clinicians and it matters to them, which is the most important part. We can screen for it even in a busy clinic, and then pass on these children to our colleagues with expertise. it does affect their performance and development, and particularly as we think about measuring impacts of our therapeutic interventions like implants for single-sided deafness, we have to consider vestibular function if we're going to get it right in terms of how we move forward. And the exciting part from our perspective is this idea that perhaps we can stimulate the vestibular system through implants and eke out some additional benefit for these children in their lives. So I'm going to finish just with a final note of we really cannot forget what drives development in children. And this is our little guy at the beginning. And his dad is from the Dominican Republic, and his dad surfs. And so what is more motivating than a little boy doing what his dad wants, what his dad does? And so here's our guy with Usher's syndrome getting up on a surfboard, despite the fact that he has bilateral vestibular loss. So we should never underestimate the power of the brain in making up for a less than ideal signal that we provided. Thanks very much.
That's a great talk. Congratulations. Just a couple of questions. I wonder your data, interesting data on the fact that children with bilateral vestibular loss actually adapt better than children with single-sided deafness and therefore putatively single-sided vestibular loss. And I wonder, there could be a couple of things going on there. One is that, the vestibular system does very poorly with fluctuating vestibular loss. And I wonder if some of the SSD kids, first of all, maybe the contralateral ear might be somewhat affected and have fluctuation. But what do you think about the notion that some of the difference between the two groups in terms of their compensating for the vestibular loss might be related to fluctuating vestibular function in the SSD kids?
I think there's a few nuances to that data. First of all, it's not clean in terms of our groups, and that's where we're taking our research next, is that the kids with bilateral deafness and cochlear implant, some of which had intact vestibular function, although the proportion of which was pretty similar in the two groups, but they're a blended group when it comes to etiology, many of whom had connexin-related deafness, and only a small proportion had vestibular impairment. The group of kids with SSD, I think the brain doesn't like asymmetry is the first bit. It also doesn't like fluctuation. And so the etiologies, I think, that may give fluctuating hearing loss, fluctuating vestibular impairment are the kids with CMV and the kids with cochleovestibular anomalies. And I think that particularly when they have asymmetric loss, which is common in both of those etiologies, it's just bad for everything. It's bad for how the brain develops because there's not a constant signal. We looked at another cohort of kids who had no nerve, because again, they're a bit of a pure cohort when it comes to our kids with SSD, and some of them had had 3 nerves in their IAC, and some of them had 2 nerves in their IAC, and again, you'd expect those kids to have pretty constant, absence. So those that had vestibular impairment looked pretty crummy in terms of their balance as well. So I think you lose marks for asymmetry and you lose marks for fluctuation, absolutely. And I hopefully will get larger cohorts that are more pure in terms of what their sensory dysfunction is, so we can do those comparisons in a much more rigorous way.
Great. And then just one other question. So your data on being able to elicit a cervical vent from a cochlear implant, it's really fascinating. I was wondering if in any of those kids did you also use goggles to see if you evoked a small VOR in response to that high rate stimulation that leads to a vent?
We didn't, but it's certainly something we'd like to do in seeing whether or not there's any eye movements associated with it. But we purely just looked for the electrophysiologic.
Do the kids note a vestibular percept during that?
No, they don't feel anything. Again, to drive it, it has to be pretty high stimulation, so it is loud, understandably. But again, now what we're trying to do is play with rates and amplitudes to try and, find there's certain signals electrically or electrophysiologically, there are different stimuli that the vestibular system likes better than the auditory system. So there may be some form of a sweet spot where we can minimize the auditory percept, but still have enough current spread to evoke something meaningful.
And do you see an ocular vamp as well as a cervical vamp?
We do, yeah. Yeah, so we were able to evoke them both.
Okay.
The prevalence of CVEMPs was higher, as it is generally,
Yeah.
but we were able to evoke both OVEMPs and CVEMPs.
Just to follow up on the question about the single-sided versus bilateral cochlear implants, you showed the sort of effort network with the EEG dipoles, and just looking at that, some of it looks like some prefrontal cortex activation, maybe anterior cingulate, things that you would expect with effort and early learning and engaged learning. So I wonder how much of it is related to the fact that kids that get cochlear implantation will receive extensive training versus kids with a single-sided that were untreated, not receiving that, as opposed to, certainly it makes sense that having some level of asymmetry would have an impact, but, I wonder how much of it is just, strategies for sort of the effortful engagement and learning being fed to the kids with the bilateral cochlear implantation versus the kids with single-sided untreated not receiving that.
It's an excellent question, and what I'll tell you is the data is cooking, because we have about 10 kids who were implanted with single-sided deafness at a very young age, so under 1, and we're waiting. The oldest is now 4, so we're waiting for them to be old enough to do these tasks, because really that would emphasize that some of this may be treatable, and also will, is a treatment by creating as symmetric of a system as we can with a normal hearing ear and an implant, or is it the training? We should be able to decipher that, so that we can't wait till they're old enough to do these tests.
Which electrodes are most effective in stimulating a cervical vamp?
Yeah.
Is it proximal or distal?
So the interesting thing is we didn't notice a difference between, so we did apex, an apical electrode, a basal electrode, and a mid-array electrode. And we had done some previous work looking, where this all began was looking at facial nerve stimulation from the implant. And again, while there's some literature out there that suggests, a mid-array electrode may be the most effective, we found no difference. And I think it just relates to the fact that you put current anywhere near that fluid and it's going to go. And so we didn't see a difference either in our facial nerve data or in our VEMP data. So that also, gives us some opportunities in terms of trying to use specific electrodes that won't decrement hearing, typically either at the apex or the base.
My question has to do with the same one that you brought up about the discrepancies between unilateral and bilateral vestibular function of cochlear implants. So one thing that we've been working on and talking about is how old we can implant our single-sided deafness children. Do you think that there is a discrepancy in maybe a length of vestibular deprivation that's causing this discrepancy, or do you think that it's maybe a minor factor?
I think when it comes to replacing sensory function, earlier is always better. And again, one of the challenges when we're looking at it from the vestibular side of things is that by virtue of the types of tests we're doing, we're always choosing older kids. And if we learned anything from cochlear implants, it's the younger ones that have the answer and the real plasticity. We've been careful in our SSD study to be very specific about duration of deafness. We started with 2 years was the only, if your duration of deafness couldn't be proven to be less than 2 years, you didn't get an implant. We've extended it now to 4 years based on the results, but we don't know where that, where it's going to end in terms of is 5 okay, is 6 okay? And there's probably not the same answer for every child and every etiology of deafness. Our kids with CMV probably heard in utero and maybe even heard for the first 2 months of life. And so perhaps their duration is longer. But I think that we shouldn't forget the lessons we learned with hearing when it comes to vestibular function. And again, there are times where we've come up short in terms of what we were expecting our device to do. And we do wonder whether or not it's because we're looking at children who are too old to expect a benefit.
I'm remembering back to the child in the balance group, and with one implant on versus the other implant on, And these implants, in that situation, when they turn on, they're giving auditory type stimuli, in no way specified by an accelerometer so it doesn't make any sense, frankly, knowing how much the vestibular system doesn't like sloppy input. I wonder, hypothetically, if the existence of a charge coming through the perilimb somehow restores vestibular function. In other words, somehow shocks back in a sick system by creating a polarization that allows the cupula, that allows the otolytic organs to actually restore function temporarily. Otherwise, it doesn't make any sense that it would have a meaningful stimulus, right? Right?
So I think that, we wondered about, whether or not any of the effects that we're seeing are just purely galvanic. So just putting undifferentiated current and driving the system into some, rate of functionality. And that certainly, there's evidence in the literature that does help. And that may be the effect that we're seeing. We tried to also dissociate the importance of spatial hearing versus electrical stimulus, and that we put our kids in this challenging environment assessment lab with their implants, and we put them in with surrounding white noise, and then we put them in with spatial, a spatial signal. So there were cars going by and people going by, and it was coupled, the hearing, the auditory environment was coupled to that movement. And they did no better in either of those two situations, which did make us wonder about just simply a symmetric electrical input. I think when we think about, and that might be the only benefit we can get, which we may get just with putting implants on. I guess the question is, can we capitalize on development, especially in children, to drive it more? And perhaps the answer is yes, perhaps the answer is no, but we're going to give it a try.
I just don't know why even a steady galvanic input would be expected to improve the function. Just because it has no information, right?
Exactly.
Or inappropriate information.
But if there's not enough resting discharge rate from the otoliths, and you give it a bias, a DC firing rate, and there's still some otolith function, then it can modulate.
So it's supercharging the physiological function, or restoring.
It's actually shown in hearing too, right? You can have a stochastic rate of stimulation that actually depolarizes some of the neural elements, not others. And so you have a higher resting rate of firing, and I think then you can detect differences that may be undetectable within the spine.
And it, may help them boost their other senses. When you watch these kids with this device on, they play around with it, right? They play around with the limits of it, and over time they improve. And so, is it a therapy device? Possibly. We hope that it's something, not to downplay therapy, but we hope that it can be something more than that. But it also just may give them some information to figure out, how do I stand up in a way that the vestibular system isn't giving them.
So I wonder if you've considered the possibility that this input is actually not tapping into native vestibular processing systems. And the reason I mention this is, it's been shown, for example, in the elderly, that you can use tactile stimuli, you can use auditory stimuli, you can use visual stimuli to create sort of an augmented input to the vestibular system. But there's also been evidence showing, for example, with brain-machine interfaces, that you can create an arbitrary neuronal signal, electrical signal delivered to the brain that can, for example, teach a monkey to learn proprioception of a robotic limb. And so in this case, you could consider that this input could be, something completely arbitrary that's not necessarily tapping into the vestibular system, and they're just learning to use this, with brain plasticity to accommodate for, and use as sort of a secondary input to balance.
And it could be auditory biofeedback, right? But the conscious effort that is required for those types of cross-modal plasticity are greater, and sure, that would be a great benefit. But I think we can't ignore the fact that we do have an electrical signal that's in proximity to the end organ that we're trying to help, because perhaps again we can drive something that is bigger than just cross-modal plasticity.
Do you see benefit in kids with the Scheib deformity? That's granted, implants oftentimes don't work as well, but I'm sure you probably implanted some kids with Scheib because they have little or no saccular function.
And so we have, the interesting thing again is that, the current flow in those kids is actually better
Yeah.
in the sense that, from a facial nerve stimulation standpoint, they're way more likely to get facial nerve stimulation, which also for us is a proxy of, where we're getting current too, because the vestibular system's a whole lot closer. I don't think we have enough of a cohort, so while there's some kids in our cohort with cochlear vestibular anomalies and severe ones, there's just not enough volume and there's too much inter-patient variability to say that it works better in these instances.
I do adult vestibular rehab therapy. And then one time I assisted a 7-year-old kid that the concussion. And then we do have the dynamic postural therapy. So I was asked to assist the measure, and then it was just eye-opening. Just the kid cannot stay still.
And that's one of my screening questions is, I ask the family, is your kid a one-speed wonder? Because kids with vestibular impairment move fast. And if you think about, crossing, you're hiking and you're crossing a little pond that's got some stones in it, you're going to do it quickly, right? Because if you do it slowly, you're going to fall in. And so these kids, that's why we miss them. They run around. They use momentum to make up for the fact that they have poor signals coming in. And so they skate fast, but they skate with their head down. So they're more at risk of concussion. And so in those kids, you definitely want to screen for vestibular impairment because that's perhaps why they got concussed. And so I think that there's these things that are different about kids that sometimes mask the underlying deficit, but they can, you can even see this kid, he's moving his head all about.
So to measure balance would be like your way need to be different, and then also probably like the way we have maybe might not be able to use the regular adult we have exercise, maybe different from kid we have exercise, maybe like a playing based. Just wondering, any good exercise or play successful from the work experience, or I believe somewhere it's your colleague, pediatric vestibular therapist from Canada, maybe somewhere in this room. So just wondering if you are aware of good exercise.
We have Dr. Cronin, who's like a world expert in pediatric vestibular function and therapy, so I'm sure she could have many more insightful things to say. I do think it has to be different, partly because it needs to be play-based and functional-based, but I think it also needs to be different because we can't assume that they have the normal framework, in particular in the setting of a congenital loss. So you can't assume that they have this triad of vision, proprioception, and vestibular function playing in and have those mechanisms that we already have to tap into. It's the difference between a prelingually deaf child and a postlingually deafened child. There is no pattern there, so I think we do have to treat them differently.
Thank you very much.
That was wonderful.